Hi, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County, and this is another episode of our COVID conversations and more. And more today is monkeypox. And joining us is Dr. Richard Leman. Dr. Leman has helped us tremendously through the COVID pandemic. So whenever I had a question where I didn't know the answer, and I said, I'll get back to you, it usually involved me calling him to find the answer to get back to us. So he's been great. He is an epidemiologist, public health physician, and the chief medical officer for health security, preparedness, and response, which during the COVID pandemic has been a big deal. And he's going to be at the forefront of what we know about monkeypox. So we'll start first about COVID, and then we'll get to Dr. Leman, and we'll talk about monkeypox and anything else which is interesting in the world. And there's always interesting stuff. So starting with the world of COVID, it's not done yet. We are still seeing a fair number of cases in the world, especially in Asia, places that did not have much COVID early on. They're still having relatively high case counts, but we're not seeing lots of hospitalizations and lots of deaths in places like New Zealand, Australia, Taiwan, and South Korea. Still not exactly sure what's happening in China. I was just listening to a story this morning that said that China has had COVID in the Shanghai region. They peaked at about 27,000 cases down a day, but just with public health measures, vaccination, lockdowns, and whatever, they were able to bring it down to 15 cases a day, which is shocking because Shanghai is just an enormous city, and they've had a relatively low death rate reported. The data from China is always a little suspect, but I think if there was rampant disease in China, certainly there are enough Westerners in China that we would hear about that. The one area that we also don't know about is North Korea. There have been some reports of disease in North Korea, but we have so little way to tell what goes on. When we look at the rest of the world, we're seeing a fairly stable amount of disease in Europe and seeing little bits of disease in other places in the world, especially South America. In the United States, we're seeing a slight increase in the number of cases, a slight increase in the number of hospitalizations, and still over 300 deaths a day. So as much as people are wanting to think that COVID is gone, it really isn't. 300 deaths a day is enormous. When you consider a disease, when you consider a condition like automobile accidents, where we have 40,000 deaths a year, about 100 a day, this is still 3 times as many as all the auto accident deaths, or 3 times as many as all the homicides. So what we're seeing is just still lots of disease. Oregon is starting, I think, to flatten out. We had lots of increasing cases over the last few weeks, but I think it's beginning to flatten out. When we look in Oregon, we see disease kind of scattered throughout. There's no particularly hot spots or particularly cold spots at this time. Douglas County, we're at about 20 cases per 100,000 per day that get reported to us. But with the holidays, we think there are probably a lot of people maybe tested at home and didn't let us know, or even clinics that were closed and didn't do the testing. So we're averaging about 21 cases per 100,000 per day. Our hospitalizations have been pretty stable. So when we look over the last 4 weeks, we've ranged between 5 and 12 a day. Looks like we're at about 8 today. So our hospitalizations also look stable. We're continuing to have some deaths, though, especially in older people, and especially in those who were either not vaccinated or vaccinated early and did not get boosted. The good news is still plenty of vaccine out there. The vaccine appears to be very effective in preventing disease, but seems to be really effective in preventing hospitalizations and deaths. When last we looked, we're still well over 80% protection for those people who are up to date on their vaccines. The other thing is that we have plenty of Paxlovid in the community. So Paxlovid is this oral pill. You take it within 5 days of diagnosis, 1 pill twice a day, and it reduces the risk of hospitalization by 80 or 90%. That's amazing, right? So people don't want to get COVID, but what they really don't want to do is go to the hospital with COVID. And so we are recommending for anybody who is diagnosed with COVID to talk to your doctor about whether you would be a good candidate for Paxlovid. We also have some of the antibody product available in town. So if you're not a candidate for the antibody, for the Paxlovid, you might be a candidate for the antibodies. The other thing that's new this week is apparently the FDA is going to look at vaccine for those 6 months to 5 years. But those who've been watching me for the last year, so we've had tremendous starts and stops with the pediatric vaccine. It looked like last November it was going to go, and then in February, and then in April. And so we'll really have to wait to see what the FDA says when they look at this in the middle of June. So if they say yes, we'll likely have vaccine for that group as early as the end of June or early July. The other thing that's out there is we're always looking at variants. Most of the variants we're seeing in the US and in Europe are the BA2, but now that the subvariants of BA2, the BA2.12.1, we're also looking carefully at the BA4 and BA5 because South Africa had a little bit of a peak with BA4, BA5 after they had their BA2. But right now, it does not look like that's going to be a big issue in the US. So COVID is still there. Please be careful, especially if you're going to do high-risk activity. And please get vaccinated. And if you're vaccinated and not boosted, please get boosted. For those people 50 and above, we would even recommend a second booster. I've had my second booster. It was actually a nothing. And actually had antibody levels drawn the next week for a totally unrelated purpose. And they were extraordinarily high. And so the vaccines do work, and they really do prevent against severe disease. But you can't, if you're alive in the last week, you've heard about monkeypox. And so Dr. Leman is joining us today to talk about monkeypox. Thanks for joining us.
Sure. Thanks for inviting me, Bob.
Well, good. So did you have anything to add to the COVID report? You're seeing a lot of better data maybe at the state level.
No, I think you pretty well covered it. We're not out of the woods at this point. And I think your point's a great one. We do have medications. If there are people who are at increased risk for severe COVID disease, we've got these medications, and it's important to get them started within the oral medications. It's important to get them started within 5 days of onset of symptoms. So it's really important for people to know if they potentially are at higher risk and to get in quickly, get tested, and get started on those medicines.
Right. And we have medicines in 5 different pharmacies in the county. We check each week to be sure that they still have doses, and they're still ready to go ahead and get it. So if you are positive, talk with your doctor about getting Paxlovid. The other thing we're seeing is we're seeing a fair amount of influenza A. And so in the pediatric clinic this week, we had 2 that were positive in influenza A, none that were positive for COVID. Is the rest of the state also seeing a little influenza bump?
Actually, fortunately, we're starting, can't say definitively, but the percentage of total tests, particularly up in the northern part of the state, that are positive for influenza A is going down. So it had been up over 5%, and now it's down around 2%. So that's a good sign. Also, we do monitoring for influenza-related hospitalizations in the Portland metro area, and we're seeing about a third of what we were a week ago.
And that is great. So I don't think we're out of the woods, but I think we can maybe see the clearing in the distance.
I hope so.
So we hope so.
It's June, for gosh sakes.
I know. Well, we always look at, so for a year now, we've been looking at what happens in the UK with COVID, because they've been a great predictor of what's going to happen to us 6 or 8 weeks later. And it looks like the UK is still having a very low number of cases of COVID. So we're looking for this summer, hopefully, to be quiet. But monkeypox, everybody's thinking about that. So Dr. Leman, tell us a little bit about monkeypox.
Well, sure. So probably some of you have already been reading about this, but this is a virus, and it's a double-stranded DNA virus. So that's the nucleic acid that's in there. It's in the orthopox genus. So that's the same genus as smallpox, but this is not smallpox. So just wanted to be clear about that. And there are 2 strains of this, one which tends to be less severe, milder disease. And at this point in this outbreak, that's the one that seems to be circulating. So that's, I think, worth noting. So just to tell you a little bit about the disease, typically it starts with fever and headache, and people may often have muscle aches, and then that's followed after 1 to 3 days by development of a rash. And the rash typically starts out as sort of flat patches. It often starts on the face and then moves out to the extremities, to the arms and legs. It can also be on the trunk, obviously. And it starts with these macules or flat patches, and then those develop into a firm lump that can be like as big around as the tip of your little finger sometimes. So they're pretty good size. They're very firm. They can sometimes get a little dimple in the top of them called umbilication. And then they typically fill with fluid and open up and scab and then ultimately fall off. And that usually takes about 2 to 4 weeks. So that's the typical way that this occurs. We have seen a lot of folks, interestingly enough, in this outbreak where they don't even have the fever and they don't have the muscle aches. And another thing that's pretty common with this is development of swollen, often painful lymph nodes, and that distinguishes this pox infection from some other much more common skin rashes.
Yes. So there's only a few advantages of being this old, but one of them is that I lived through a time where chickenpox was very common, and so that's the pox disease that's most common that people mostly know about. It's very different from monkeypox, but if you've not seen chickenpox, it could be confused. The other pox disease that we see a lot is a thing called molluscum contagiosum. And as a pediatrician, we see that every day. And these are tiny, not huge like the big one, the one Dr. Leman is talking about. These are tiny, really asymptomatic, tiny little pearly little lesions. They also can have a little bit of an umbilication, but for anybody who's seen a lot of molluscum and a lot of chickenpox, I don't think they're gonna confuse these. But what we're asking is that if people do have an unusual rash, that they talk to an old person who could look at a pox-like rash and help you to differentiate it. We do, but do we think we're going to have widespread cases in the U.S.?
I don't think so, but we'll kind of see how things go. However, it's worth pointing out that this typically, historically, has been an infection that people get from animals, and so this is something that you see in Central Africa, in French West Africa. That's where the virus appears to have originated, and typically, it's from exposure to various animals, often rodents. Interestingly enough, there was an outbreak back in 2003 where somebody brought over some giant Gambian pouched rats that just happened to be infected, and those were kept in a pet shop near a bunch of prairie dogs. And doggone it, the poor prairie dogs got infected and then went around as pets for various people. And so a few people got it from the prairie dogs, not anticipating that in this case. And there was no spread beyond that. It was just prairie dog to person transmission. In this case, though, this outbreak's a little different in that we are seeing cases in a number of countries where typically the monkeypox virus isn't seen. And usually in that situation, somebody's traveled to one of the countries where monkeypox is more typical to circulate. And what we're seeing in this case is some people are getting monkeypox, but they have no history of travel to, say, Democratic Republic of Congo, and they also haven't been in contact with somebody who's been ill, who's recently been there. So there may be some transmission going on, but all in all, this is a hard virus to catch. If you think about what we call the basic reproduction number, that is, for one person who's sick with this, if you don't do anything to try to stop it, how many more people are going to get sick? And the number with monkeypox is about 2. So maybe for every person who's sick, if you don't do anything to try to prevent spread, you might expect 2 more people to get sick. That's compared to some of the Omicron variants. Omicron's like up in the 6 or 7 range. The Delta strain of COVID was a 5, and measles is the granddaddy of them all, like 12 to 18 additional cases. So this is a hard one to catch. It requires pretty prolonged close contact.
Yeah. And so we wouldn't expect this to spread in a pandemic way. So public health people are always worried, but we're not always panicking. And
No.
that's the good news. So I don't think there's any panic with this, but there's a lot of interest because this is a new and different disease. I've been in pediatrics for 40 years, have obviously never seen a case of monkeypox.
Right. And monkeypox, interestingly enough, we've known about the virus and we've known about the disease, but it's just what's unusual about this outbreak is that we're seeing some folks who are getting it who have not been to a place where it usually circulates.
And unlike COVID, where there are a lot of hospitalizations and a lot of deaths, my understanding is that with monkeypox, there have been very few hospitalizations and no deaths so far.
That's right. And again, this is the milder strain, and no deaths. There have been, I think, a bit over 500 cases worldwide in countries that don't usually have monkeypox circulating. So that's a fair number. And in the US, I think we're at about 19.
And the other good news with monkeypox, if there's any good news about monkeypox, is that unlike COVID, for which there was no treatment and no vaccine, tell us about the treatment or vaccine for monkeypox should we ever need it.
Right. If we actually end up, lo and behold, having a case of monkeypox in Oregon, there is a vaccine called Jynneos, and it is actually FDA licensed and approved for prevention of monkeypox. And the CDC has what's called the Advisory Committee on Immunization Practices. They're the smart folks who get together and kind of figure out how do we use these vaccines. And so if we had a case and if we had folks who had like a high risk contact with the secretions from the rash, for instance, or some other high risk contact, if you get this vaccine within 4 days of that exposure, it may well end up preventing illness entirely. It still has benefit in terms of helping to make disease less severe if you get it within 14 days.
And then are there treatments?
There are treatments that could potentially be used, but as you pointed out, Bob, most people are not needing them. There are some medications that could be used. They're not licensed by FDA for treatment of monkeypox, but if somebody were really sick, say they got so sick that they had to be hospitalized, we can get medicines through CDC that could potentially be used under what's called an investigational new drug protocol. And there are several medications that could potentially be used in that situation. We might also consider that if there's somebody who is felt to be at very high risk for severe disease, and that might include young children. There's potentially a risk if a pregnant woman gets this, that it could be transmitted to the unborn baby, and that's something we don't want to see. So a pregnant person might also benefit from treatment.
And the final difference from COVID is, you'll remember in the beginning, it was not easy to test for COVID. So first reported in December, we didn't really get a good widely available test until March. But my understanding is that there is a test up and going that can at least do the preliminary test here in Oregon.
We can do it at the public health lab, yeah.
So we can do it here, so we won't be in that same state of not being able to tell early on. So right. Monkeypox is interesting, but nothing to panic about. Not very contagious. If you get it, it doesn't even appear to be very, very serious. We do have a vaccine. We do have a test. We do have potential treatment. So this is all good news. So don't lose a minute of sleep over monkeypox. What do you lose sleep over, though, Dr. Leman?
Well, my wife sometimes has the Jimmy legs, so that could be that. Just kidding.
Yeah.
So, um, I don't know. I feel like we do this all the time, Bob. You know, we've done this for influenza. We every year is a bad flu year. We just kind of work our way through it. We've worked our way through COVID reasonably. I think uh, people in Oregon have been pretty amazing in terms of enough of them doing the right thing in terms of preventing spread to others if they get sick, and many people have gotten vaccinated, which has helped to protect them against severe disease. And so, this is just what we do, right? This is what you and I do. So right now, I'm not losing too much sleep, and I hope to keep it that way.
Good. Well, I rarely lose sleep, although there are things that we're worried about. I mean, we do worry about emerging diseases. This is another disease. So last week we talked with the state veterinarian, and he talked that most of the new human diseases actually come from animal populations, as does this one. We talk about preparedness for things like earthquake. Earthquake is one of those things that we can't predict, and if did occur, it could be really very severe. And Dr. Leman is at the state getting us ready for all of this stuff. So the good news in preparedness is that if there's nothing happening, it looks like they're not doing anything. But that's the time that people in preparedness actually do a lot of work to get us ready. So when this happens, there is less panic and less upset. So
yeah, well, and we appreciate the ability to work with the folks in Douglas County so that we can all be ready and we can all be more resilient when that next wildfire or that next flood or that next problem comes down the road.
well, those are weeks coming up. So weeks coming up, we're going to talk about fire, heat, and other kind of disasters that we might see to get people a bit ready. But for today, it looks like monkeypox is there, but not much to worry about. Pay attention, but don't panic. And for COVID, it looks like we're not out of the woods, but we might be able to see the edge of the woods from where we're at. So those are all the good news. So thanks for joining us. We'll do this again next week. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer for Douglas County. Thank you.